Welcome to a Stanford Medicine 25 video on abdominal wall pain.
I'm Dr. George Meyer, clinical professor of medicine and volunteer faculty at the University of California at Davis, and a gastroenterologist. The purpose of this session is to emphasize the examination of the abdominal wall. So we will not be focusing on the full examination of the abdomen. We should start by reviewing the concept of nociceptors. For our intents and purposes, there are two kinds of nociceptors, the A delta and the C. The A delta is the fiber that allows us to localize pain from a bite, sting, knife, gunshot, and we can point exactly to the area that hurts. On the other hand, the C nociceptor innervates the peritoneum, periosteum, and gives us a dull, slow onset pain, and we cannot localize it. The most common sources of this pain will be in patients who've had previous surgeries or laparoscopic procedures. Often, in people who have long scars, the pain may be at the edge, at the corner of the scar. In patients who have had laparoscopy, the laparoscopic insertion point may be the area of tenderness. In those patients who have not had surgery, often the pain is along the rectus sheath. This patient has pain in his right lower quadrant. Can you show me where it hurts?
Right here.
Okay. Relax. Oh, yeah. That hurts when I push there. Can you straight leg both of her legs at the same time, please? Does that hurt more?
Yeah.
Okay. Increase of the pain while straight leg raising or sitting up is a positive Carnett sign and indicates that the pain is probably in the abdominal wall. Probably the most common cause of abdominal wall pain is something called abdominal cutaneous nerve entrapment syndrome, abbreviated ACNES or ACNES. And usually it is caused by nerves coming around and hitting the rectus sheath, turning anteriorly with the vascular bundle. At the base where it makes that turn is a fatty deposit that usually acts as a shock absorber, and sometimes we think inflammation occurs there and causes this pain. Treatment is best achieved by injecting a local anesthetic as well as a long-term anti-inflammatory. I like to use 1 ml of 1% lidocaine and 40 milligrams of triamcinolone. I often mix them in the same syringe and inject directly into the trigger area. The lidocaine gives us local anesthesia for 2 to 3 hours, and the triamcinolone usually kicks in at that time and gives us longer-term pain relief.
This has been a Stanford Medicine 25 video on abdominal wall pain. Thanks for watching.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.